Good evening, sir. Good evening.
Hello, everyone. Good evening.
Yeah, we're just
Am I
going
audible?
live. Yes, you are audible. We'll be going live in a few minutes.
Yeah, sure. So it's not a problem. How is Kerala?
Yeah, fine. We're waiting to hear you.
Uh-huh.
And especially Trishur is important for you.
Yeah. Uh,
Okay.
so I
Tanu?
think in Delhi it's
Yes,
very
we are
cold.
live, ma'am.
Okay. So, good evening to all of you. We are starting the live program of TACO Monthly Academic Meet. Today, the first inaugural session of this year. And we're lucky to have with us Dr. Surat Senjem from RP Center. He's the additional professor in community ophthalmology and, of course, has done a lot of work in blindness control, assessment, and assistive technology for the blind. For the introduction, let me invite Dr. Jyoti.
Good evening, everybody. It is my great pleasure to introduce Dr. Suraj Singh Senjam. He is additional professor working currently in Community Ophthalmology, RP Center, AIMS, New Delhi. He had done his MD in Community Medicine from PGI Chandigarh. He also received a master's degree in Public Health for Eye Care from London School for Hygiene and Topical Medicine. He has been working on assistive technology for visual impairment and published more than 80 studies, including abstracts in peer-reviewed journals and conferences. He is one of the key members for the rapid assessment of assistive technology in India. He has delivered many national and international invited guest lectures on assistive technology and disability. He has designed a simplified classification of assistive technologies for the education of students with visual impairment. He has edited a book entitled An Introduction of Assistive Technology, published by Nova Science, New York. Also written a handbook on assistive technology for students with visual impairment. Also developed many training manuals for visual rehabilitation and training. He is instrumental in establishing the National Research Training for Low Vision and Rehabilitation Center in RP Center. He is one of the key investigators for the National Blindness Survey in 30 districts of India and National Trachoma Survey, India, supported by the Ministry of Health. We welcome you, sir.
Okay. So thank you. Thank you so much. First of all, it is my privilege to be here on this platform and to interact with many ophthalmologist trainees and experts and faculty and other distinguished invitees in this platform. And I must also thank Dr. Sudha for inviting me for such a wonderful interaction and talk. Am I audible, right?
Yes, sir, you are.
Okay. So this is the first interaction with you all. If I'm not wrong, so from RP Center AIMS. So I'm not sure whether any guest lecture from RP Center AIMS in such a good, wonderful platform. So anyway, let me share my slides and. So, is it visible now?
Yes, sir, visible.
Okay. So, I hope every one of you can bear with me. So I have around 50 slides, so it will be around 1 hour. So if we have any questions, then you can ask maybe in the between, after the sessions, after my talk is over. So now, so my talk is on visual disability and assistive technology. Before that, I must thank to Dr. Jyoti for a nice introduction. Okay. So, so when you talk about the visual disability and assistive technology, so this assistive technology is relatively new terms. Earlier, of course, it has many definitions by different organization. Okay, so now the WHO has defined specifically assistive technology, And in that definitions, in that spectrum of assistive technology, so assistive technology for visual impairment and blinds, so it is one of the very, very important topic. So in WHO, there's a Global Alliance of Assistive Technology. We call it GATT. So I think many of you might have heard of it, this GATT community, GATE. So this is WHO initiative in 2017. So this GATT community is pushing a lot of importance and emphasis to work on assistive technology globally. So in India also, the WHO push the ministry as well as World Health Organization India to start working intensively on assistive technology because this visual disability is growing day by day. So now in worldwide, there are more than 1 billion populations having some form of disabilities. Here, this visual disability is one of the important areas. With this, so first I will talk about disabilities, and in the context of disabilities, I will share what are the visual disabilities in terms of low vision, in terms of functional low vision, in terms of blindness. And further, I will talk on magnitudes, magnitude in Southeast Asia, including India, and impact of these visual disabilities and management in terms of vision rehabilitation and assistive technology for visual impairments. And the last, I will briefly mention about the person-centered approach. We call it PCA for visual disability service. How is PCA? So I will give talk 1 or 2 slides on that. Now coming to the Right for Person with Disabilities Act 2016. Okay, so earlier in 2006, so India recognized there are 7 disabilities, but now in 2016 it expands from 7 disability to 21 disabilities. So here blindness and low vision is at the top. It's very, very important when you in the context of this right to person of visual disability. And now, as you know, we have learned the sequence of disease event. So it start from the disease and comes to the impairment and next disability and handicap. So in 1980s, at the beginning, WHO defined this sequence. Within this sequence, disability was used to be defined in between. But now WHO is not recognize this sequence because disability is defined as a separate entity now. So WHO does not recommend to use the word handicap because the handicap word is very offense, is insulting to a person. So WHO recommends not to use the word handicap. If you say someone is handicapped, so if the person is well educated and well say qualified, and then they said it's a very offense language and this is insulting. So WHO says never use this handicap word. So in 2001, so the WHO International Classification of Health and Functioning, we call it ICF-2. So in define disability, the with 3 components. The first is impairment, activity limitation, and participation restriction. So of course, the impairment leads to disease leads to an impairment, and once the impairment has, then there will be some individual limitation. Okay, so see here, so impairments, so some kind of body, not able to perform as it is. Once there is impairment, then there is an activity limitation. Those are difficult to in executing tasks, daily tasks. This is the individual functionality. And the last component is very, very important. That is a participation restriction. If someone is having impairment and some individual functionality problems, and this participation restriction in a society, in the environment. Okay, so this last component has been given a lot of importance because there are some factors which influence this participation restriction. What are those factors? The social factor, environmental factors. Okay, these two factors influence the participation of people with disabilities. Okay. So now coming to disability. So it is very complex, as I told you, because nowadays many health conditions, not only the eye, there are so many other chronic debilitating disease. So it is day by day the disability is, the proportion of disability is increasing. So for example, in HIV and the multi-drug resistance, this chronic debilitating disease, now it is in some countries, so far not in India, it is considered to be a disable. So what we observe when someone ability is threatened, and then what we observe is this view as a due to the impairment. And suppose someone is not able to do some work because of impairment, because of some problems. So we always see this is because of impairment, but we hardly think about other factors which leads to restriction and the activity limitation. So for example, factors like social and environmental factors, they influence a lot uh, in making someone as a disabled. Suppose someone is having some problems, so other factors also compounded to become a more disabled. So this is very important coming up concept, this medical model and disabled social models. Okay, so we doctor view disability is a medical problems, and those people with disability, they said, no, it is not only the medical problem, it's a social problems. So society's barriers, challenge, and so many social and environmental factors leads to a disable. So then finally, WHO, it's not neither medical problems or social problem. It is a balance in between, because so the equal importance. So when we manage the disable, so you need to focus on medical component as well as social component. So that's why this slide is very important. What I believe is, so because we are going to manage visual disability, so this medical component, those impairments, those low vision, at the same time, the social component also should be given equal importance. So now coming to the visual disabilities. So we all know that when you talk about the visual disabilities, so it is low vision and functional low vision and blindness. Okay, so what is low vision then? Low vision is some lay person defined as low vision is referred to an inability to perform everyday tasks, routine tasks. Say suppose, for example, despite of wearing glasses, despite of correction, despite of condition management, someone is not able to read newspaper, not able to recognize face, not able to do their routine work. So these are the that criteria that we consider as a low visions. And if you want to use some technical terms, so in eye care service, then low vision is defined as a less than 618, but equal to or better than 618, 360 in the better eye. Okay, so after treatment, after conventional correction. Okay, so low vision, when you define low vision, so these are the definition of the low vision. But coming to the functional low vision, so this functional low vision is one of the very, very important area when we manage low vision. Okay, so what is low vision? A person with low vision is one who has impairment of visual functioning, even after treatment or best correction, and has a visual acuity of less than 618 to light perception. So even after management, even after you done a lot of work, lot of treatment, and if the person still have his vision from less than 618 to light perception, so this is the function low vision. In a similar way, that based on the field of vision, it is also defined less than 10 degree from the point of fixation. That are symptoms of low visions, so we can quickly skip it. Now coming to the blindness. Blindness, we do have avoidable blindness and unavoidable blindness. So here we talk about unavoidables. So when you say disabilities, so once you manage, once you've done what you have to do to the best level, if the blindness is, not able to manage, then it becomes unavoidable. So blindness as a visual disability means when the blindness, despite of management, when the person is having, his or her vision less than 360 in the better eye, despite of management, despite of best correction. Okay. So this, you look carefully this chart. Okay, the first is the visual loss range, starting from less than 618 up to 360, and from 360 to up to 160, and from 160 to positive light perception and negative light perception. So what WHO defined? Low vision is, we are talking about base corrected, okay, after management, after conventional correction treatment. So low vision is from 618 to up to 360. This is the low vision. Okay. On the right side, the blindness, the entire category, less than 360 up to no light perception. And what about this functional low vision? Start from the less than 618 up to positive light perception. Okay, it excludes the negative light perceptions when you define functional low vision. Now coming to the magnitude very quickly, this is a general magnitude of the blindness and visual impairment based on presenting vision acuity. So here we are talking about the best corrected vision acuity. So this is the latest survey. There are, latest data we have, around 217 million people visually impaired and 36 million people are blind. Okay, around 90% of them live in low middle income countries. Now coming to the low vision. So this is data from Southeast Asia. So when you see India, the prevalence of functional low vision, okay, this is 1.05%. That means around 14 million in India have low vision problems. Okay, the current survey, that's RAP survey, so 2015 to 19, so there's a similar proportion. So we found it around 1.03%. So this report, it is now, it is in the public domain. So the Ministry of Health has already released this report in 2019 November. Okay, so you can get from the ministry website the latest report on prevalence of blindness and visual impairment as well as low vision. And now coming to Nepal and Myanmar and Bangladesh. Okay, so there are some of the countries from Southeast Asia. It's about the prevalence of low vision. Myanmar is, is considered to be, worst performance in terms of eye care service. Now, different causes of low vision based on the APET study. This Andhra Pradesh eye disease. The amblyopia, it's one of the most common. And of course, this retinal disease, there are so many retinal problems, so it's merged into retinal disease around 37%, and amblyopia is 27%, and rest is optic atrophy, glaucoma, corneal disease, and congenital eye anomalies, and ophthalmos. So these are some of the causes of low vision in India. Now coming to the impact. Okay, so before we go to the management with the help of assistive technology, so we should know what are the impacts, because managing a person with a visual disability, so we should not only think or focus on impairment aspect, the eye aspect, because you should know other impacts of the other impacts to the person due to the visual disabilities. So the impact is first in terms of individuals, families, and society, of course, in the provider as well. So the managing visual disability is very challenging for provider. So let's see here. So the first, we know that low vision and blindness is a chronic health problems. We cannot manage it. So it has to be there with the patient, with the person, and it affects the performance in daily living and basic self-care. So in terms of hygiene, simple cutting a nail, okay, and cutting beard and massages, daily living activities, it is compromised, and it affects the mobility in terms of indoor and outdoor movement. So it is, a problem for a person with severe low vision and blind, and compromise independent living, and then also affects the social integration, and it also affects the ability to learn, because someone is blind, totally blind and severe low vision, and then person is, it poses a lot of challenges in terms of social integration. And now for students education achievements, so the student may not be able to achieve the education performance, and employment also it affects a lot, and education opportunities. So you see many of the blind, the literacy rate in India, see around 10 to 15% among the visually disabilities. Okay, the World Bank report. And increased chance of falls and injuries, maybe in the bathroom, maybe indoor and outdoors. And this may lead to a secondary health problems, maybe fracture, maybe some other, you know, uh, uh, injuries. And then finance management, the person with low vision and blind, it's difficult to manage his finance, even not able to recognize the Indian currency. And even the medication, because, that people with visual disability with, age as it, so that someone having medication for hypertension or diabetes, so medication is a problem. Okay, and the mental health problems and significant impact on families. These are the very, very, challenging. If a children is blind because of ROP, so because of stage 5 ROP. So just imagine the families, what kind of challenge and impact by this, visual disabilities, and even in community as well. And then finally, the significant economic cost burden. Okay, so the person is not able to work properly, not able to do a job. See the economic burden. There's a, and other aspect is, in terms of accessibilities. So the accessible is an issue, not able to access because of, problem in infrastructure, and then lack of access to services, and compromise in hygiene, sanitation, as I have already mentioned. And this another aspect is the human rights issues. And frequently ignorance and stigmatizations in the community, in the society, in the workplaces, and loss of opportunities. So these are some of the impacts that a person with visual disability frequently face. And recently, another impact, because of this COVID-19. So this is very unexpected, because a blind person, they may, they are, to get contracted from the COVID-19 disease, because there are so many other factors. Because a person with blind, so they rely on touch. So since they are not able to see, so this is another, challenge because of this pandemic. Now coming to the management. So here the idea is, when you want to manage a person with visual disability, so you have to think the whole gamut, not only the body impairment. So coming to this flow chart, so first is body impairments, the eyes, low vision and blind. So for that we need the ophthalmologists and optometrists and eye care providers. And at the same time, then social problems and environmental issues, this will be tackled by the rehabilitation professional working for visual disabilities. And then assistive device also. So I want to have a separate talk on this assistive device, because nowadays assistive device is gaining a lot of importance and is growing day by day, especially for person with visual disabilities. So of course I'll be talking on that. And then at the same time, we also remember community-based rehabilitation. Okay, that as a being an eye care professional provider and rehabilitation professional, so remember this community-based rehabilitation matrix. So health, education, livelihood, social empowerment. So there are 5 strong components that should be kept in mind when you manage a person with low vision or blind. And then this entire, management complex is should be within 4 pillar of this rehabilitation branches. The first is medical and vocational and social and psychological. So each and every pillar, it carries a lot of importance. The first medical is, being a doctors, being eye care professionals, we should work on this And which at the same time, we also should have a knowledge about these vocational trainings for a person with visual disabilities, because they need to survive, they need to live. So what sort of training for their livelihoods? So we should have a knowledge on that. And the social, okay, the person with blind, he has to marry, he has to integrate with the society, he has to talk with the friends, friend circles, so other social, interrelation. So this is also another big importance in terms of managing visual disabilities. And psychological, this is psychological rehabilitation is very, very important for a person who become blind in the, mid age, in the middle of the life. If a child, if someone is blind right from the birth, since birth, so the child will, accept, okay, I'm blind, so I'm blind, so I can not do this work, I can do this work, they will accept. But a person who becomes blind in the middle age, uh, so that in that context, it's very, very challenging. So psychological counseling and rehabilitation is very, very important for the person who become blind in the middle age, in the in the later part of the life. So as you know, so we cannot manage this entire gamut by one person. So there are team approach. We need a team. So only the eye care professionals with other team also, other professionals, other staffs, other peoples who are expert in this disabled management. So we need it. But how will you proceed this such an intense resource uh, management of people with visual disability? So this article this year. So I have designed one. Uh, I would say this is. This is most feasible, and this potential that can can work out while we manage a person with severe visual disability and blind. Okay, so here in this band diagram, you see on the right we have eye care facilities. Uh, And okay, the blue line is the blue circle is community-based organization. So these two organizations, and we have a manpower. So we should work together to be able to provide the whole gamut of the of service. So in the direction of person-centered approach. Okay, this is person-centered approach. A blind person, to manage a blind person. Okay, this entire range of 6 circles we need. So 1, 2, 3, 4, 5, 6. Okay. So the first is enhancement of visual function. So this is all those eye care providers. So we have to manage it using all those technique, evaluation, assessment, and prescribe some magnifier, non-optical, optical devices. So these are the first tasks to manage a person with visual disabilities. What is the second? Promote and help well-being and support accessing healthcare service. So this is the another second important component. The third is respect the dignity and choice. If the blind person wants to do something which is quite feasible, so we should respect that choice. We should not ignore it. And the fourth is creating accessible environment and independent living. So this is accessible environment is one of the very, very important, even in the hospital, even in the home, even in the workplace, everywhere, even the shopping mall, everywhere. Okay. And this support education and livelihood activities. This is all vocational trainings, other activities of livelihood. And the last is empower them, okay, to participate in society, okay, and mobilize those platforms formed by the disabled society and improve their communication. So these are 6 very important components while we consider. We should consider while managing a disabled person, people with visual disability person. So now coming to certificate is very important. So we always remember this issuing disability certificate in India. Okay, 40%, we know it is the cutoff. And this is a matrix we developed in 2017, and it was notified in Gazetted Government of India in 2018. Okay, so and now assistive technology. Okay, so as you know now, addressing people with disability, including visual disability. So we know the impacts, we know the problems, challenge, everything. So now we need the assistive technology, because this assistive technology is one of the very, very important we should keep in mind while managing a person with visual disability. So this is the book I just I edited. This is the book that it also encompass other assistive technology for neurodevelopmental disorder, neurodegenerative disorder, and autism. Okay, not only the vision impairment. So it has the book describe about this, assistive technology for other disability as well. Now, there are lots of, as I mentioned earlier, there are lots of assistive technology are coming up uh, nowadays. So these are the various assistive technology. See here, the lots. This is a picture I click from Royal National RNIB, Royal National Institute of the Blind. So there are so many devices. So they have a huge, huge building and a lot of thousands of assistive technology. Okay, in RNIB. See, there are multiple assistive technology for the people with visual disability. And now how to classify? The problem is how to classify this visual disability assistive technology, because there are hundreds of assistive technology for visual impairment. Then the classification, how to classify it? It becomes a complexity. So thank God I visited some of the schools for the blind in Delhi, and there is no uniform classification of assistive technology for visual impairments. But when I visited this few school for the blind in Delhi, and then I discussed with the special educator and NGO, school principal, and then I asked about, is there any classification of this assistive technology that you have in your school? And teacher said, no, we don't have. We just use randomly for writing, for reading, for game, everything. So we don't have any specific classification of assistive technology. So when I visit and start talking and observe the school students, okay, how these students are being, use this assistive technology for what purpose? At the same time, I discuss with the, this school special educator and trainers and principal of this school. And then and based on this observation, so assistive technology is first is body sense being used. Okay, so sorry. So the visual base and tactile base and sound base. So assistive technology for the people with visual impairment could be visual base and tactile base and sound base. Okay, so that example. So large print book is a visual base. We need a vision, an optical and non-optical magnifier, and tactile base with a braille reading books, and sound base with a DESI book, liquid sensor, color detector. Okay, these are the body sense that to be used while using assistive technology. At the same time, based on the activity of the student. So this is very important. What sort of activity are being done by the student with visual disability? So, so first is education. So education is, pre-academic learning. What are the devices that we can be used for a pre-education learning, pre-academic learning, and devices that can be used for reading, writing, mathematics, and science, and at the same time, and orientation and mobility, and games and daily living activities. These are some of the classification that found after I observe and discuss with the school authorities. And this is another based on the evolution of the assistive technology for visual impairment. So now another, broadly we can classify it as technology is traditional assistive technology. This traditional assistive devices or technology is those magnifiers, near magnifier distance, and the braille and CCTVs, video magnifiers. This comes under the traditional assistive technology. And now coming to the mainstream assistive technology or device. So this mainstream is like your smartphone. Okay, smartphone and tablets and laptop and screen reader, because this becomes a mainstream assistive technology for people with visual impairment. The third is the state of the art, because this use some artificial intelligence nowadays, state of the art assistive technology. So there are so many assistive technology that based on artificial intelligence. So nowadays it is coming up, it's evolving. So there's some of the handbook I have written. Okay, there's some of the research that I have conducted in the recent times. And so now coming to the classification. So the first is user and AT characteristics. Okay, based on the characteristics of the users and the assistive technology. Okay, so first is how to classify assistive technology for visual impairment and identifying the potential beneficiary based on best character vision equity who can use it productively. I said productively. And what criteria should be followed to encourage the use of assistive technology. So as I told you earlier, has been shown in the earlier slides. So now see this 80 potential user. So the classification is this way: low vision to 160. So it includes the low vision also and some part of the blind criteria. Okay, so low vision up to 160. That means from less than 618 to 160, and on the right side is less than 160 blindness. So based on this, so now we have here user characteristics. Okay, so what is the best assistive technology to be prescribed to a low vision or blind person? So you have to define, we have to categorize low vision to 160, the person having low vision to 160, and in other way, the person having less than 160 blindness. So these two categories. So this low vision to 160, a student with binocular vision best character vision equity is from less than 160 to 618 to 160. So they are the potential beneficiary of assistive technology based on visual skills like optical magnifiers, like large print book. So this group of people, they can use very productively. So the recommendation is this: someone is having these categories, this assistive technology based on visual skills can be used very productively. At the same time, less than 160 blindness. So a student with binocular vision, the BCBA less than 160 to no light perception. So this category, so we should not recommend. It's not productive to recommend those visual based assistive device. Like it's no point of recommending a child having this, uh, you know, visual problems, a large print book. So the child will not be able to read, even using magnifier. So it is not a productive. So that's why in this group we should encourage to use those visual substitution assistive technology, like those tactile and sound-based assistive technology. And another classification of assistive technology based on the AT characteristics. As I told you, first user characteristics and the assistive technology characteristics. So this is a visual-based assistive technology based on visual skills. What are the examples? Large print book, magnifier, typoscope, and CCTV, okay, video magnifier, and so on. And the tactile and sound AT, we call it TET. I name it TET. This is our Braille book, DESI books, all those. So these are screen readers. These are the tactile and sound based. So this is technology classified into two groups, either visual based and tactile and sound based. So this is prescribing assistive technology. So here, once you have a patient here, you categorize patient category 1 and 2. So category 1, what is in by category 1? Category 1 means less than 618 to 160, and category 2 is less than 160 blindness. Okay, so once you get this categorize, and then to prescribe the assistive technology, first in terms for mobility, a patient having with category 1, so you can prescribe guide cane. So this patient do not require a walking long cane, because this patient is a low vision. So you can prescribe guide cane. Guide cane is just very simple. So the person whenever required, the person can use it. It doesn't mean that it's always to be used all the time, right? And at the same time, category 2. So you have to train about human guides. This I'm talking about mobility. Okay, so human guide, how to guide a blind person. Okay, walking with the long walking cane. Okay, you need this for mobility. And for the activity of daily living, category 1, category 2, and category 1. For category 2, you need all this training. Okay, because they are, they have a very, very severe visual impairment, see, in less than 160 blindness. So they need to be trained about basic self-care, about eating, dining technique, dressing, finance management, okay, brushing, shaving, everything. And now coming to the education. So you divide into category 1, category 2. If the child is having this category 1 visual impairment, so you can prescribe visual based assistive technology like large print book, typoscope, and the CCTV, video magnifier. Okay, these are and so on here. And category 2, so the tactile and sound based. So it is always better go for tactile and sound based. Okay, so and others vocation training, social, these are, it doesn't have any category. In a similar way for adult also, or for children also, adult and children. Okay, so this is similar. Last few slides, the digital technology. Now we talk about digital India. Okay, so we frequently use smartphone, computer, laptop, and data, internet connection, everything. So what will happen to the blind person? So are you going to let this special people left? So we need to also talk about this accessible technology, digital technology for blind people. So these are some of the accessible technology for the blind people. We have the screen reader, smartphone, talking device, dot watch, dot mini, smart glasses, and a hands-free mobility wearable tool. There's so many. There's some of the examples of assistive technology. So now I will focus on smartphone, accessible application. There is a function required when you talk about digital technology. Okay, so digital technology in terms of magnification, object identification, optical character recognition, contrast enhancement, and so many functioning can be done by digital technology. So this study conducted in School for the Blind in Delhi to know that how many schools possess digital technology in terms of screen reader and smartphone. Okay, so I covered 24 schools, and very few schools they have a screen reader, and smartphone application only 8 school out of 24. Okay, so this is some of the a little bit data on it. So yeah, this slide is I want to give a minute in this slide. So issue. So someone is blind, and then most of the smartphone to use a smartphone it relies on the visual function. So it needs heavily visual. It relies heavily on visual function. Okay, so for a blind person, what will do? So there is this human and mobile interaction. So we cannot rely on visual function because they have a compromised visual function. They don't have a vision. So to make it accessible, so this should be based on touch and gestures. So these two are very important. That's why this accessible feature in a smartphone and accessible application. This is very, very important. So then what are those accessible application? In a smartphone. Okay, in the smartphone itself, we do have a built-in accessible features. Built-in accessible feature. On top of that, there are lots of accessible applications that can be used by a blind person or by a severe low vision person. So there are so many applications: Be My Eyes, Wiser, ID Pro, SuperSense, TapTapSee, Money. So remember, each and every application, their utility is different. Of course, some application may have overlapping uses, but they have their unique uses. Okay, so again, this accessible application is evolving day by day. There are so many accessible applications are coming up. Recently, this Kibo is application which can read PDF file, image file. Okay, a blind student who who enroll in university, in college, they use Kibo. Kibo is very, very useful for a blind person. This is recently very popular. This Kibo accessible application for a blind person. Issue is the problem is language. Because most of this application, so it is you have to command in English, and the synthetic voice coming out from the mobile phone is in English. So hopefully. So in some of the application like Money, okay, and Be My Eyes, it does have a Hindi language. But many of the apps, I would say, more than 90% of the accessible application is in English language. And some of the application, this is some about this awareness about the application, accessible application. So around 101 patient. So during this pandemic, so we provide tele-rehabilitation service. So we just collect some data and the smartphone on among the callers, callers. So, more than 50% of them, they don't have a smartphone. And about the awareness of the application, so 80% of them, they are not aware of any accessible application for the blind among the callers, among the 101 callers. So this is the way forward. So to improve the access of this assistive device and application, the first is 4 P's: people, product, and policy and provision. So these 4 P's very, very important to improve the access about the smartphone application as well as assistive technology. Okay, so last slides, if I'm not wrong. So this is visual disability is a chronic health problems, as we know, and it's globally because of aging population. The magnitude is increasing even in India. The magnitude of visual disability is increasing day by day, and this person-centered approach, as I saw in the Venn diagram, so should be a potentially an ideal to approach to manage a person with visual disability, where resources are very limited. And assistive technology for visual impairment is an indispensable tool for management, indispensable tool. And vision loss can be categorized as a low vision to 161, and number 2, less than 160 in blindness, when you thought of application of assistive technology for visual impairment. And visual-based assistive technology will be useful for people with low vision to 160, and this tactile and sound-based assistive technology will be useful for people with less than 160 and blindness, or you can increase. Thank you for your attention. I think I took a lot of time. Thank you. Anything we can.
Thank you, sir. That was a very enlightening talk. I'm sure all of us ophthalmologists, we don't know how to manage blindness and how to manage people with visual disability. Sir, could you stop sharing your screen?
Yeah.
So the question is, where is this available and how do we ask, how do we get it?
Yeah, that is very good questions. So, as you know, this assistive technology for visual impairment, for the students, for the adults with visual disability. So, access and availability is an issue in India. So we are facing a lot of challenge. Like we are not able to, say that, okay, this working can is available in this particular shop, this particular outlet. So this is the big challenge. What we do here, we ask them to contact this NIBS Dehradun. Okay, and some of the eye care facilities like Stroke Eye Hospital. So we just ask them to get it from these centers, and sometimes from in Amazon also some of the assistive technology. Suppose, for example, simple cane, walking cane, is available in Amazon, but not all. So in South India, there are 2 suppliers. One is Akriti and Omtau. So if a person who wants to buy some good quality assistive technology, so we give phone number of these 2 suppliers, because in North India I'm not very much aware of what are the different various agencies that can supply this assistive technology. So this is the issue, challenge the availability, and hopefully, Dr. Sudha. So now we are under process of estimating the access of assistive technology among disabled, including people with visual disability. So we will be able to estimate the access among the disabled population. So once we have this data, then the ministry can think of, okay, this is the data and we need to work on it, and we need to start opening different various outlet like a optical shop, because in optical in each and every optical shop you will not find this assistive device, assistive technology. A simple magnifier also they don't have. So hopefully, after this survey, so this is a countrywide survey. We choose 6 countries divided into 6 different zones. No, 5 different zones: south, east, west, center, and northeastern, like that. So we will have data, and then we can present the data to the ministry. Of course, this is a ministry and WHO initiatives. So it's working. I mean, the big agency, working a lot to improve the accessibility of assistive technology.
So we have a KSOS president with us. So I think he can comment on this, can help us out.
Yeah.
Babu sir. Babu sir, any comments?
Hello.
Hello.
It's a very exhaustive,
Hello, sir.
very useful talk.
Hello, sir. Hi.
We were not knowing so many advancements are happening in this field. The assistive technology itself is
Right,
a new
sir.
terminology for me. And the grouping of the low vision groups into visually assisted technology and tactile assisted technology, all are new things.
Right, sir.
Thank you.
Right, sir.
Sir, welcome.
Hello, sir.
Sir, it was very nice talk, very enlightening. So, lot of knowledge. And something like I heard about some computer that will read. Some software is available. If you keep the book over the computer or something, computer will read the book, and the blind people can hear it. Is some software or computer available like that? Reading computer or something like that?
Yes. We call it screen reader. So we do have screen reader. Yeah, it is we call it JAWS software, NVDA, Supernova, and there's so many softwares are coming up which needs to be installed in the computer, and a blind person can easily send an email and type in the Word file, can work. So this screen reader is very useful. And nowadays, so even the Kindle. Kindle. So if we are able to install this screen reader in the Kindle, and then what is being there in the Kindle, it can be read by the screen reader. So far in this Kindle, so there's no screen reader that can be installed. But this is my idea. If some screen reader is coming up and installed in the Kindle, then it is very useful for a blind person. So I answer one thing. These screen readers are being used by a blind person in Delhi, students for online, because nowadays teaching, it is like academic is, maximum, most of them, it's online. So this screen reader student use for to attend class.
I see. But the software is expensive. The software and everything.
No, sir. This NVDA is it can be downloaded. It is freely available, and some of the softwares like JAWS and Supernova. So this is not a free. So we have to buy, and this NVDA is free. It can be downloaded.
But it is only for English, not local language. It is not available.
That's the problem. That's the problem. It's the English.
That's how everything is English only. So
yeah.
Even Hindi is not available. I think Hindi also.
Yeah, Hindi cannot read the Hindi. But this Kibo is simple screen reader. It has to be installed in a mobile, so it can read Hindi. Kibo, Kibo, Kibo. Kibo, B for Bombay.
So all these you can get from Play Store. Where do you install it from?
No, it can be installed in Android as well as
Apple. It available? Is it available on Play Store? Where is it available?
You have to download. It is available free. Yeah, these applications, this accessible application for the blind and visual impairment, these are all available free of cost in online. It can be downloaded. It's all free. But some of the screen reader and application, these two are different. So this accessible application for a mobile, it is free. Most of them are free. So it can be downloaded easily and installed in an Android phone as well as an Apple iOS operating system.
Sir, one more question. So I am interested more on spectacle and everything. I heard about lot about the smart glasses or something. So the blind people can see through that glass or something.
Yeah, smart glass. Very right. Yeah, smart glass. Yeah, smart glass is nowadays again is very much coming up. This is artificial intelligence.
Yes.
So artificial intelligence. So the Israel company has developed one smart glass. So it has to be attached on the this is a small device like a thumb size. It is attached on the frame, and then it can read what is there in front of the blind person. So its name is Orcam, 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 Orcam. It is developed by Israeli, one of the Israeli company. And even, sir, many robotics in Japan, many robotic assistant are coming up for a blind person, robotic assistant.
Yes.
Yeah.
But this smart glasses will give some idea what is obstacle or what is in front of the face.
Okay.
Yes, something like that.
Yeah. So let me explain first about this accessible application that is SuperSense. This SuperSense is once you install in our mobile, Android based or iOS, the Apple, then that it can easily identify what are the objects surrounding, nearby surrounding. If a blind person use this application, he has to just hold like this and scan it, and everything will be okay. This is the computer. This is the here is the glass. Here is the table, chair, sofa. Everything will speak out by the mobile itself. So this SuperSense is very useful to identify any nearby objects and surrounding. And for navigations, also this GPS navigations that Google app, Google what do you call it? Blind people are using this for navigation. And another thing is, sir, Be My Eyes. Let me tell you, Be My Eyes. This app is very useful for a blind person, because the usage is just Be My Eye is once we install, okay, and then we have to register a blind person as well as volunteer, like volunteer, a sighted volunteer. I have to install, I have to register to this Be My Eyes application. So I myself can be volunteer. At the same time, a blind person, a blind student has to register. And so suppose for a blind person needs some help, okay, and then the blind person will open this Be My Eyes app, and then this apps will randomly call nearby volunteers who register in this Be My Eyes app. Suppose if a blind person wants to wants to identify color of the clothes. So this is our experience. So the blind person just open the application app and call, and then the volunteer, the random volunteer nearby, okay, he will pick up, and the camera will be open, that is built in this application, and the sighted person will speak out. Okay, the blind person, we have to hold it, and then from the volunteer will speak out, oh, this is the red color, this is the blue color, this is the white color, like that. Even the searching object also, the blind person, he lost his something, maybe some can or some some daily use items. So the blind person can randomly call anybody. So at the same time, any volunteer will pick up and will help it. This is very useful for sometimes for railway confirmation, like say this is our experience. A blind person wants to know whether my reservation is my confirmation railway ticket is confirmed or not. Though he dial up to Be My Eyes, and the sighted person from anywhere, maybe from south, maybe from north, anywhere, so you just identify, okay, your ticket is this, and it is not yet confirmed, or it is confirmed. So it is very useful, Be My Eyes. But we have to register both blind as well as sighted person in this application. And this smart glass also, it is very useful for navigation.
So there's a question: is there a opportunity for us to learn Braille online?
Braille is not very difficult. We think that Braille is very difficult. Braille is very simple. because it cannot be very simple, complex, because it has to be learned by a blind person. So never thought that, because we think that Braille, we have to touch and read. It's very simple, not very difficult. So online, there are certain automated Braille learning device. Okay, so device. So this automatic Braille learning device, it doesn't require an educator. A blind person can easily learn with this device. This device will, step by step will tell you what is A, what is B, and how many dots in the brain cell, okay, everything. But online, of course, there are available about, materials, okay, and simple language about the Braille. I can share you what we have about this Braille, technique, how to read it and what to do, and all those, steps of the Braille learning. So online, it must be there. YouTube tutorial, it is there. Anybody can learn from YouTube.
Okay, thank you, sir. No more questions. We move on to a case report. So I would like you to see that also. Stay on,
Sure.
please. Yes.
Yeah.
So now one more small question.
Yeah.
We have some putting some chip inside the eye. So totally blind people put some chip inside the eye, implant something. Then the blind people may be able to, they use a computer, they can see or something. Do you have any idea about that? Some experiment is going on?
No, I am not sure. It's not possible. It depends on what kind of this, because the retina is damaged, optic nerve is damaged, and I don't think it's not like a cochlear implant. It's not like that. So
Okay, sir.
I'm not aware of it.
Okay. Dr. Sujata, please take over. Dr. Sujata and Dr. Jodi, please come and chair this session.
Good evening. We have a related case which is going to be presented by our PG senior resident, Dr. Sitara. I would ask her to present the case. Please hear, and we have some doubts to ask you, sir. Sitara, start.
Good evening to all. Today I'll be presenting the case of a 24-year-old male who came to a casualty with alleged history of fall from bike. He had no history of loss of consciousness, seizures, vomiting, or ENT bleed, and had no complaints of blurring of vision, flashes, or floaters. On examination, his vision in the right eye was 6.9 and vision in the left eye was 6.6. The color vision was normal in both the eyes. Ocular movements was full in both the eyes. He had a lacerated wound of about 8 by 4 by 2 centimeter, which extended from the lateral edge of right eyebrow up to the medial edge of left eyebrow, and a hemorrhagic chemosis in the temporal aspect of the right eye. So barring this, the other anterior segment was normal in the right eye, and the anterior segment was also within normal limits for the left eye. The pupillary reaction was normal in both the eyes. There was no relative referent pupillary defect. The fundus examination was also within normal limits. So CT head was taken for this patient, and it showed fracture medial and lateral walls of bilateral orbits, as well as fracture of the anterior, medial, and lateral walls of the bilateral maxillary sinus. Now, the patient was managed with oral antibiotics and analgesic. 2 weeks the patient he noticed a field defect on the right side. So he complained of a difficulty on seeing objects in the right side, and he noticed this more while he was driving and also while reading when he could not see the right side of the page. So this is the field of the patient. As we can see, the temporal half of the right eye field is lost and the nasal field of the left eye is lost. So suggestive of a right homonymous hemianopia. So the patient was advised to do an MRI brain, and this also came out to be normal. Now for his symptoms, the patient was prescribed a 4 prism diopter basal prisms in the right eye, and he became symptomatically better. He is now able to appreciate objects in the right side better, and he also has less difficulty in driving as well as for reading and writing. So this is how the patient sees. So you can imagine the plight of this patient, who is a young 24-year-old male. So homonymous hemianopia refers to visual defect that affects both eyes equally and can occur either to the left or the right of the midline of the visual field. So there are various causes for this, but by summarizing, we can say it can be stroke, tumor, trauma, infections, AV malformations, or demyelination. So several studies have explained certain compensatory mechanisms that these patients adopt so as to manage the visual disability. So these include anomalous head posture as well as an exotropia that are contralateral to the side of brain damage. So by assuming an anomalous head posture, the visual field gets centered and the blind field gets moved to the side. And by adopting exotropia, this creates a more panoramic view and this can broaden the functional visual field. So by management, there are various techniques. You can do an audiovisual stimulation training. So here you can use multisensory stimulation to improve the vision. Here, the patient will go through an intensive program that takes about 4 hours a day for 2 weeks, in which areas of the visual field, which are both intact as well as the affected areas, they're stimulated using sound and light. You can try explorative saccade training. So here you train the patients to make exploratory saccades without any head movement towards the area of the visual field which has been lost. You can try visual restoration therapy. So here the brain is stimulated and by the process of neuroplasticity, that is the process by which new synaptic formations are made. So by this process, the tissue gets reorganized and you can some amount of visual field recovery occurs. You can also give visual aids to the patient. So here the patient's glasses will have a special prism that is mounted onto them. So this will shift the location of the image so that it is brought to the field of vision. So you can give high power frontal prisms. The advantages of these prisms are they are thin, they are lightweight, and they can be cut and placed in different positions on the spectacle lens. You can try peripheral prism spectacles, which can expand the visual field of the patients. And also there are new type of optical devices like the Peli lens and the Gottlieb visual field awareness systems. And also try basic letter. And also we can suggest changes for attention to the areas that they do not see naturally. So this mostly involves adjusting to the disability. So by these methods, even though we cannot cure the condition, we can provide some amount of relief as well as visual rehabilitation so that we can improve the quality of life of these patients. Thank you all for your kind attention.
Stop. Thank you. Thank you, Sitara, for the presentation. Sir, I would like to summarize this case for you. This is a 24-year-old male who had an injury 2 months back and was managed conservatively. 1 month late after this injury, he realized that he's not seeing objects clearly in the right side of his visual field. And he came to us and he's a student, he cannot read properly. So first we gave him this glasses, that is we prescribe prism, that is optical aid, that is we prescribe prism only in the right eye, that is about 4 prism diopters base out, that is the base of the prism is in the blind area. Now he's saying that his field of vision has improved, and we have trained him in how to read and certain compensatory mechanisms also I had advised. But the problem the patient now facing is that he cannot work on the computer. Can you suggest anything to help him?
Yeah, so so first of all, this right homonymous is hemianopia, right? This patient.
Yes.
So first of all is have you thought of prescribing some disability certificate? Because does it affect the central field of vision? Because it has got
yeah. It appears to be so.
So yeah, so for this person, first of all, you need a guide cane. So the person may not require a walking long cane, because the right side is not able to see. So whenever he requires while mobility, it doesn't mean that he always use guide cane. You know, guide cane means it's no like the length of the guide.
Avoid bumping into objects in the non-seeing area. That's what I mean,
area. Yeah, exactly. So there's a difference between the guide cane and long walking cane. So long walking cane, it is up to our, this the height of the long walking cane, it is between our chin and sternum. but the guide cane is up to, our waist, so not very long.
Okay, sir.
So the person can use it, this kind of guide cane for mobility. And for computer training, so if he is not able to use computer properly with his remaining vision, and then so we recommend him to use about this screen readers like
Screen readers.
yeah
Yes, sir.
NVDA, because this nowadays NVDA is very user friendly. So sometimes it needs 3 months training and 6 month training. So there's some NGOs who they provide this computer training using this screen reader, either NVDA, yeah, JAWS, yeah, Supernova. So I'm very much sure in your area in Trichur, there must be some NGOs that provide computer training. So with the help of this screen reader, then because these things you need to sensitize the patient at the hospital level. Once you don't sensitize, they would know it. What are the available assistive device technology for the blind person? So being working in the eye hospital, at the first point we should be aware of what are the available technology for a visual impairment person. So this screen reader, with the help of screen reader, he can easily operate the computer. That is the second thing.
Yes, sir, do you know the name of any NGO in South India, like in Chennai or?
Any NGO. So
Yes, sir.
so your teacher like in Bangalore and
Okay,
Chennai,
Bangalore is okay.
I know some of them. Bangalore is okay.
Okay, sir.
So I will send some of the NGOs that we work. Occasionally we touch with them. So I will definitely email some
Sir,
of the
I will mail. I'll
yes
contact you over mail,
Uh-huh,
and so you can provide the necessary information at your ease.
yeah
Okay,
definitely
sir.
definitely. So we'll provide.
That
And
will
then
help
in this
him.
particular case,
Yes, sir.
yeah. So in this particular case, you ask what are the problems faced by this child in terms of education, okay, in terms of computer.
It is only
What is his age? His or her age?
24, only 2 months now. So he's slowly becoming, aware of all his problems, and
Okay.
he cannot explain it properly now. That's the problem now.
Okay.
What he
Okay,
says is he
So
cannot do that.
Sujata,
Drive.
I have one point.
Yeah.
Yeah.
Jyoti.
Actually, when you give prisms in hemianopia, there can be an apical scotoma which can affect the central vision, like central field of the patient, so their field expands. So ideal would be a peripheral prisms. Those are those Paley lenses. They
Okay.
are like Hyderabad-based people are making it commercially. It comes around some 6,000 to 12,000 range like that. So yeah, he may be experiencing a gap in the central vision. That is why he may he is
that's why
not
I'm
able
telling.
to see
Yeah.
that is because of that apical scotoma that will appear
Yeah.
as a gap in the central vision when they use higher prisms.
He's just using only just four
Yeah.
diopter now.
Yeah, but for hemianopia, I think you need more prisms.
Yeah, we need
Four
up
will
to
be less.
up to 8 you can give now. That is what I have learned. But as a trial, that's only just starting one month only. So we just started it with a 4 diopter prism. It's definitely improve. There is improvement, but and all these factors he's not happy about. So
Another technique is there eccentric viewing technique. So someone can go through about it. I think Sitara can go through about it. What is eccentric viewing technique? So for such cases, this technique you have to advise and you have to train them how to use it, eccentric viewing technique. So our optometrists here in RP Center, some few of them, they do it. So you can, read about it, this eccentric viewing techniques, because so just have a look on it.
Okay, that's looking to that side, blind side.
The gaze, sudden gaze.
And make more movements, purposeful movements to that blind side, like that. Okay.
Yeah. And then talk about this digital technology. Okay, for this particular child, because particular
Person.
patient, so all about digital technology, about the screen reader, smartphone. If he is willing, he or she is willing,
Okay.
so it will be very helpful.
Okay, sir. Thank you, sir.
Dr. Sujata, out of clinical interest, apart from the assistant technology, where's the lesion? Why is there's only external injury? Where's the lesion?
Yeah, that is what's troubling us. This actually is a patient was referred to us, and when we asked for MRI, but it was not contrast. Maybe we missed some lesion. We think it is something in the optic tract. Both orbits walls were fractured. Maybe it's something injuring the optic tract.
Optic
Tract. That's what we are thinking at present.
Something like a traumatic optic neuropathy, but something happening upper level, maybe.
Yes, sir. Only on one side. Both orbits have fractures, but more only in one side.
Are you given systemic steroid or
yes, sir. At the acute period, he was managed by systemic steroids and antibiotics, and he had no other problems. No loss of.
Vision 6966, that means optic nerve is functioning. Still, there's a hemianopia. That's why.
Yes, sir.
No brain damage, nothing.
Nothing evidence, sir.
No memory loss, nothing.
No history of loss of consciousness, sir.
Okay, very interesting case. For us, interesting, but for patient is the problem. Patient has the problem.
Okay, I think it has been a very successful meeting, the first of our TACO. And thank you, Suraj sir. And I would like to ask Dr. Sujata to give the vote of thanks.
Good evening, ladies and gentlemen. It's my pleasant duty to offer the vote of thanks. On the behalf of all TACO members and on my personal behalf, I would like to thank Dr. Senjam for giving such an illuminating talk. We always stop at the medical aspect. We diagnose blindness. This is the cause for blindness. We may even say what is the percentage of blindness, but we never used to think beyond that. You had opened our eyes to the impact this blindness has in their family, social setup, and so on. And also, there's no need to say that your detailed talk about assistive technology was extremely useful, and rather we gained a lot from your talk. Thank you, sir. Thank you again.
Thank you. Thank you.
Now I would like to thank the our senior faculty who had agreed to chair the session and who had rushed to take part in this session, although they were engaged otherwise. Our Honorable KSOS President, Dr. Babu Krishna Kumar, and Dr. Andrews, sir, for being such a sport and involving in this lively session and make it so interesting for everyone. Thank you, sirs, for your presentation, participation. Now, I also thank all the senior faculty and all my TACOites for joining this session and making it a grand success. Then I would like to thank KSOS and Dr. Rajesh Sukumaran for giving us this Zoom platform to conduct this digital meeting. And I would definitely like to thank Dr. Bastian and our own Tanu for organizing this on Zoom and Facebook Live. And it will be a mistake if I don't thank my president for the guidance and all of my TACO team for standing behind us and making this first academic session a grand success. Thank you all. Thank you.
Thank you. Thank you, Harshada. Thank you. Bye.